Welcome, everyone, to HLAA North Bay of California May meeting. We're located north of San Francisco in Marin and Sonoma counties. I'm Sarah Ozer, president, and Jim Ozer may appear as our tech host. Alan Katsura, Diablo Valley chapter, will be editing and uploading this meeting to YouTube, HLAA California sites. You can tell your friends about it to watch it later. Kelly DeCamp is a captioner with April Chandler, and she's our remote captioner today. The mission of HLAA North Bay is to improve the world of communication for people with hearing loss through information, education, support, and advocacy. So, Tana, you're next.
Hi, I'm Tana Cooley. I'm Vice President of North Bay HLAA chapter. And today we are very gratefully welcoming Colleen Polite, who is a Director of Audiology, a Doctor of Audiology, and she's presenting on the what's and whys of audiological evaluation. Dr. Polite is Assistant Director of the Douglas Grant Cochlear Implant Center at UCSF, which has been involved in developing and implanting cochlear implant systems for more than 35 years. The team that she's on includes experienced audiologists like herself, surgeons, psychologists, and other experts. Dr. Polite evaluates patients for cochlear implant candidacy, and after implantation, she worked with patients over time to get the best hearing results with the technology. Please feel free to put your questions in the chat at any time, and we will bring these questions to Dr. Polite's attention. But we have a very special request today. Our presenter will not be taking questions about over-the-counter hearing aids, as that is not her area of expertise. So please save those questions for another meeting at a later date. And now let's welcome Dr. Colleen Polite.
I would really like to thank you so much, Sarah and Tana, for inviting me to be able to present some information to your group. I used to, I think, present about once a year, and then I don't know what happened. I think it's maybe been 4 years since I presented. I think right before the pandemic, I may have had my colleague come out and speak to the group, give you a different face maybe. Yeah. So thank you for welcoming me back. So yes, today I am going to be talking about the audiological evaluation. And I'm not sure about all of your experience with hearing tests and counseling over the audiogram and what happens during the audiological evaluation. Some of you may be able to explain audiograms to other people because you're so well versed in it. And perhaps there's some of you for whom this is a newer experience. But I do hope at the end of today's meeting, everybody will have gained some piece of information that is new to them. If it is okay, I would like to go ahead and share my screen so that I can move you through a PowerPoint presentation just to assist us with some visuals as I talk about completing audiological evaluations. All right, thank you so much. Is everybody able to see my screen now?
Yes.
Yes.
Great. All right. So an audiological evaluation is typically carried out at the request of a patient, a loved one, a referring professional when there's some concern of the potential for there being a hearing loss. So what is involved is being able to evaluate that individual's auditory system and be able to make the best recommendations, communicating information clearly so that the patient can understand it. Because we realize that at the end of the day, the patient is going to make decisions about what course of action to take. Want to be sure that we are evaluating the auditory system the best way that we can. And that includes using both subjective data, that might mean patient reports of what they're experiencing, the patient responding, if they're hearing sounds or not, in addition to objective data, which means the patient doesn't have control over it. It's just testing how the auditory system is responding to stimulation that we are exposing it to. And then based on that information, we can formulate some recommendations on what options are available to the patient for their consideration. Audiological evaluation actually begins before we get to the sound booth. It starts right off the bat with talking with the patient. We're observing how that patient is able to communicate so that we can adjust what we're doing to make sure that the patient is able to understand us. But we're also asking questions. Some of you are probably able to come up with some of the things that we would ask. Are you familiar with some of those questions that would be important during an audiology evaluation? What kind of questions have you been asked? I think you can unmute your mics if you'd like to respond. The questions that we ask are things such as whether there's anybody in your family who has hearing loss, if you have a history of having ear infections, if you're having pain in your ears, if you have dizziness or imbalance, if you've had ear surgery. So once we collect that background information, that gives us some idea of things that we may be looking for or expecting to see when we're doing the hearing test. But I think it's really important for us to also find out if the patient themselves has any concerns. And oftentimes patients will come with some other person, a family member, a very close friend, who may also be able to chime in and share information about concerns or observations about how that individual is communicating or areas where they struggle. When we do a hearing examination, we're actually looking at as much of the auditory system as we can, the peripheral and some of the neural function as well. The external ear, which you see highlighted on the illustration on the screen at this point, includes the part of the ear that you can see, which we call the auricle or the pinna, that's on the side of your head, as well as the ear canal, and it ends at the eardrum because the eardrum closes off your ear canal at the end of it. And the one way that we evaluate that is by using our otoscope to take a look into the ear canal. That way we can visualize the ear canal as well as hopefully be able to see the eardrum. And so I'm going to just show you a few images of types of things that we might see. And hopefully none of this is too gross for any of you. I don't know if any of you are kind of squeamish about seeing things on the screen. If you are, then you can close your eyes. But what you're seeing on the screen right now is a normal appearing left eardrum. And that would be like a very close look. So if we put the otoscope in, and or we use a microscope. This is what the eardrum would appear. It's kind of this pinkish, shiny color. We could see the light reflection there that's coming off at about 7 o'clock and other landmarks very clearly. In a normal ear, we'd probably see something like this just as we insert our scope in, which means that there's normally some earwax in the ear canal. Earwax is not a problem in and of itself. And then at the end of the canal, you can still see the eardrum quite clearly. But earwax can become a problem if it is completely blocking off the view of the eardrum and we cannot see what's beyond it. Impacted earwax like this that is occluding the ear canal can even be a source of things such as feedback if the patient wears a hearing aid in that ear, because the end of the earpiece where the sound is coming out may just kind of bounce up against that wall of wax and reflect back out of the ear to the microphone and cause whistling and squealing. It can also cause a decrease in hearing with or without a hearing aid. What you're seeing right now on the screen is a condition that we call stenosis. Stenosis means that there's a narrowing of the ear canal, and you can see by comparison to the previous images that now the opening is very small and it doesn't take much debris or earwax at all to close off that passageway, and we obviously are not able to see the eardrum in this ear canal. Ear canal is demonstrating an infection in the skin of the ear canal. It's what we call an otitis externa, which basically means an infection of the outer ear, the ear canal. It can be extremely painful and responds usually nicely to treatments, medications. Now here's an eardrum that doesn't look anything like the first couple of images that we saw. It's hard to see any of the typical landmarks. That's because this is an ear that has an infection behind the eardrum. This is a middle ear infection or an otitis media. Very common in childhood, but there are some adults who are plagued with ear infections. Also, very painful, can produce a reduction in hearing, which I will show later on the audiograms as we continue through talking about the testing that we do. Who knows what this is? You able to see that?
Ruptured eardrum.
It is. So sometimes because of trauma, it could be from an ear infection where so much fluid got built up behind the eardrum that it ruptures the eardrum. It sometimes happens because of trauma from a foreign object into the ear. It can also be there because of placing what we call a tympanostomy tube or a pressure equalization tube in an ear that is chronically getting fluid and ear infection. So on the inside, on the opposite side of the eardrum. And sometimes once that tube falls out, it may leave a hole that doesn't heal. But that also can cause some change in ability to hear tones. And here's an example of that pressure equalization tube in the eardrum that helps to keep the middle ear space dry so that the fluid doesn't build up and become infected. Here's an example of a foreign object in the ear, which you probably can easily recognize as probably one of the more common things besides earwax, but a foreign object, in this case being the tip of a Q-tip, at least the cotton swab part of it that got stuck in the ear. So we check the ear canals first to see what condition they're in. In some situations, we may not want to put something in the ear because we could push something down further into the ear. And so we need to check first before we proceed with the next part of the hearing exam. And now I'm going to tell you about checking the middle ear, which includes the eardrum and the space behind the eardrum. Within that space are the three smallest bones in the body, which you're probably familiar with. Those are called the malleus, incus, and stapes, and they have a nickname, which are the hammer, the anvil, and the stirrup. And one way that we assess the middle ear is through something called tympanometry. And so these tent-like tracings that you see on the screen might be something that you have seen on your audiogram as well. And tympanometry is a way of measuring the movement, the flexibility or mobility of the eardrum. And the way that happens is we create an airtight seal in the ear, and then we change the air pressure within the cavity of your ear canal. Because the eardrum should be flexible, then the eardrum moves in and out as we apply positive pressure and negative pressure into the ear. That's the test when you have it done that you may recall feels like you're ascending or descending in a plane because that air pressure is changing. In the middle of the screen right now, you are seeing normal tracings for a right ear and a left ear. We see that the eardrum is moving nicely. It is having the normal amount of movement and at about normal atmospheric pressure. On the right side of the screen, you're seeing that there's really no movement of that eardrum. Now, based on other measurements that are part of the tympanometry, we can tell, does it look like the eardrum's not moving because there's a hole in it? And so if there's a hole in the eardrum, it's not going to resist the air pressure because the air pressure is just going to pass right through the eardrum because of the hole. Is the hole because there is a pressure tube in the ear and the pressure tube is open as it should be? Or is it because there's a pressure tube and it's blocked and there's fluid behind the ear and now the eardrum can't move because that fluid is pressing against the eardrum? So we can tell things about the function of the middle ear space. There's even a condition where the bones, which are supposed to be flexible, can become immobilized, and that prevents the eardrum from being able to move as well. In addition to those three bones, are also some muscles. And one of them in particular is attached to the smallest bone, which you can see right here, the one that's called the stirrup or the stapes. And that small muscle will contract or tighten up, stiffen in response to sounds that are perceived as loud. And when that muscle stiffens up and contracts, it tightens the eardrum so that it doesn't have the same amount of movement. At the same time as we are checking for the reflex by putting a loud sound into that ear, we are measuring how that sound is either reflecting back to our measuring equipment or being allowed to pass through or being admitted through the eardrum. So you can imagine that if something is stretched out tight and you threw something against it, like even just a coin against the tight fabric, it's going to bounce back, right? But if it's loose and you throw something at it, it's not going to bounce back as well. There's not going to be any snap back. So the eardrum does that with sound. When it's tight, more sound bounces back. If it's loose, sound passes through. And so we can check to see if that auditory system is perceiving the sound as loud, and does it cause that muscle to tighten up and respond. That most people associate with a hearing examination, the part where they are listening for beeps and pushing a button or raising the hand. That can be done under headphones, And most of the pictures that you find show headphones, although quite honestly, most commonly in my clinic, we use inserts. So you probably have been tested that way as well. And an insert are just small pieces of foam that are connected to cables that go to our audiometers, and those fit in your ear. Now, when we do the testing, either through the headphones or the insert, what we're really doing is testing air conduction. For the inserts, the sound is traveling down your outer ear, along your ear canal. Then it's engaging your middle ear system by vibrating your eardrum, which causes a chain reaction in the ossicles or the middle ear bones. And then finally, that action creates movement in the fluid to the cochlea or the inner ear that sends a signal from the nerves there to the brain, letting you know that a sound was heard. So we're testing the entire mechanism of the outer ear, middle ear, inner ear. Let's get translated onto your audiogram as the X's and the O's. So we've got X's and O's for right ear and left ear. They may or may not be color coded depending on the system that's being used or if it's a photocopy, but the circles representing the right ear, the X's representing the left ear, and we're measuring that for different tones or frequencies from low pitches to high pitches, and documenting the softest level that the individual was able to hear each of those tones in each ear. In some cases, as you see here, instead of X's as we get across the tones going to higher pitches, we have boxes because the difference between the ears was great enough that to keep the good ear from listening, noise was put into the good ear to determine what the poorer ear actually requires to be able to hear the tone. So as you look at your audiograms, you might see some boxes. If it's the opposite way where the right ear was poorer, you will see triangles in that case. Also, we'll have patients listen for tones with a box that's placed on the bone behind the ear. In that instance, the tones will sound the same, but now the transmission of the stimulus is not having to go down the ear canal, activate the middle ear space, and then the inner ear, but through conduction of that oscillator that's placed behind the ear, the stimulation goes to the inner ear, bypassing the outer and middle ear. That results in greater or lesser signs, like you see up here, or in brackets. Sometimes carets are used. Just depends on the system that's being utilized, the method for documenting the bone conduction thresholds. In this case, the brackets or the greater lesser sounds are close to the air conduction symbols. So that would indicate that the hearing is no better by bone conduction than it is by air conduction. That would be confirmation that the source of the hearing loss is not the ear canal, it's not the eardrum, nor the space behind the eardrum where the bones are or any of the bones, but it's in the cochlea, the inner ear. Look at this audiogram. It looks different because the brackets for the left ear bone conduction are much higher on the audiogram than the boxes are. So this shows us when the patient listened through the headphones or the inserts, we needed a lot more volume before they could hear any of these tones than they did when we put the box behind the left ear and introduced noise to the right ear to be sure the right ear wasn't responding. This is something that we might see in a situation where a patient has had surgery in the middle ear, or where they have a situation where the bones are not moving, or even with a completely plugged up ear because of earwax. We might see something like that. In this case, I think this was a patient we saw that had a tumor in their salivary gland that required some surgery, and as a result of that, created this problem with the conduction of the sound. So that sound had to be louder when heard through the ear canal. And that brought on this difference between listening through bone conduction versus air conduction. Most people who come in and are seeking a hearing test are reporting concerns that they're needing repetitions, they're not being able to understand the television, they don't go to movies anymore, or they have difficulty if they go to theater. So speech understanding is primary concern. It's not about necessarily hearing beeps and whistles. So we also test speech. The first measurement that we do often is a speech reception threshold. That tells us how softly can speech be presented to an ear, and the person can still understand it correctly 50% of the time. And whatever that value is, we expect it to be consistent with how well they hear the tones. So it also allows us to double check our test results and the patient's responsiveness to different stimuli to tell us that it is reliable and we tested correctly and the patient understood the task. So if we saw a big difference between the average volume needed to hear tones and the lowest volume that speech could be understood, then we need to troubleshoot to figure out why that would be happening. But for example, this speech reception threshold came directly from the prior audiogram where there was normalish hearing in the right ear and then that severe hearing loss in the left ear. So we see the same thing for words, that they could understand words in the right ear within a normal level, but at a severe hearing loss level in the left or hearing ear. In addition to looking at the softest volume that speech can be understood, we also test how clear does speech to the brain through this auditory system. So rather than presenting at a soft volume, the speech is presented at a satisfactory, if we can reach that, the hearing loss is not too great, a satisfactory volume, and then see how many words does the patient repeat correctly. And that gets represented somewhere on the audiogram as a % correct. We look for some consistency or expectation there with certain degrees of hearing loss where we see that there's very poor access to much of the speech range. It wouldn't be unusual to see then a poorer percentage score. But if we saw there was good access to speech and poor speech understanding, that may lead us to recommend or to do other testing to find out why, when the patient hears the sound, are they not able to make sense out of the words that they hear. So it's another way for us to double check reliability between the tests, but also diagnostically to know if we need to look for other sources of hearing problems. So having gone through the audiological evaluation, I would like to open the floor to see what questions you have based on information that you've heard, or about something that you maybe have experienced yourself or noticed on your hearing tests. I believe, Richard, do you have a question or comment?
I do. For a hearing test, during a hearing test, um, does ringing in the ears, um, I don't know how to describe this. Does it negatively affect the test? I mean, you're testing for the higher tones, but you've got this ringing. So is that um, uh, negatively affecting the test?
I think I understand what you're saying, and it's not uncommon for us to conduct hearing tests on individuals who report tinnitus. We can do some things to try to make the sound you're listening for different from your tinnitus that you're experiencing. So we may warble the tone, pulse the tone, those kinds of things to help it sound different. But it can be confusing for some patients, especially if their tinnitus seems very loud. And in that sense, I think it does make it challenging for a patient to know at the softest level that they can really hear it. And we may be testing more the softest level they can hear it above their tinnitus. By and large, usually there is some hearing loss in that range, though. So I think that it still gives us a reflection on whether the hearing is normal or not normal in those regions where the tinnitus exists.
Second question. If you're going through the test and you can't tell the difference between your tinnitus or the sound that you're supposed to respond to, do you just guess and indicate that yes, or do you just let it pass and not do anything?
We do tell patients to guess. If you think it's there, to go ahead and guess. Because we have a check recheck way of measuring before we record the response, if it's just a guess that was off, then it's not going to be very repeatable. But I find it helpful when a patient communicates to me that they're having trouble hearing the tone because their tinnitus sounds very much like it, or it seems so loud to them. It just helps me to know too, and can explain if I'm seeing some false positives. In other words, the patient's raising their hand, but the tone is not there.
Oh, okay,
So
thank you.
communicate that to your tester.
Thank you.
You're welcome. See that somebody's asking about the tests and values for cochlear implant qualification. You know, there now it's not as simple as it used to be. You may or may not be aware that cochlear implant candidacy has expanded tremendously from 20, 30 years ago, and then even just in the last 3 years. So people who have normal hearing in one ear and a significant hearing loss in the other can be a candidate for cochlear implant. Individuals who have hearing loss in both ears, but one is much worse than the other, may be a candidate, along with the traditional moderate to profound hearing impaired listener. So it's not just about the tones, it's also about how much speech is understood. Once the most appropriate fitting or setting for hearing aids are in place, and then under controlled circumstances, delivering recorded materials and seeing how well those words and sentences are understood. And to some degree, unfortunately, insurance may dictate who is a candidate for a cochlear implant. Does that answer the question? Is there something more I can tell you that would help?
Can you hear me?
I can.
Okay. I'm a patient of VA, and I have been told by some private practice clinicians that I would qualify for CI. I am told by VA that I do not. Apparently, they have different thresholds and tests that they use. And that's why I'm trying to learn as much as I can.
It sounds like that kind of falls in the bucket of the last caveat that I threw out there, that insurances, whoever's covering it, they can have criteria that is not the same as what the FDA criteria is. And that's a difficult place to be. I've had some patients who were able to change insurances to go on an insurance that would consider their test results as meeting the criteria for coverage, but not every patient is in a position to do that. And it seemed like Leslie had a question.
Yeah, I have two questions. Can you hear me?
I can.
Okay. The first question is, how much subjectivity is there in the audiogram, and in particular, the speech section? For example, if the audiologist says 5 and I repeat hive, do I get no credit? Do I get some credit? And then the second question is, if we're talking about hearing aids, can a hearing aid specialist do an audiogram in the same way that an audiologist does it, or do you need an audiologist to get an accurate audiogram? Those are my two questions.
Okay, thank you, Leslie. So for the first question, it depends on what the speech test is. So for word recognition testing, which are the standard tests on the audiogram, it's right or wrong. There's no partial credit for it. So what we are actually scoring is, was that word repeated exactly as it was presented? On some of the tests that we do for cochlear implant candidacy or post-operatively to check the outcomes with a cochlear implant, there is partial credit. So we score not only the words correct, but also the percentage of the phonemes. Those are the sounds in the speech. For example, if the word was Bob, there are 3 sounds: the initial B sound, the middle vowel ah, and the final B sound. So there are 3 phonemes that we can score. If the patient said mob, M-O-B instead, they would not get credit for the word, but they would get credit for 2 out of 3 of the sounds in the word.
Now, does it make a difference? Let's assume that I have a high frequency loss. Would it make a difference if there was a male audiologist with a low voice doing the speech versus you? Might that affect my outcome, or is that somehow built into the?
Yeah, people often with sloping, meaning high frequency hearing losses, often report that they do hear deeper voices better. When you actually do spectrograms about the differences in the fundamental frequencies between typical male and female talkers, it's not huge per se. So whether they're actually understanding the male or the deeper voice better, or just hearing it better, or is it a volume thing that a louder voice gives you more access to sound than a softer voice? So it can be a combination of those things. The other question about whether you have to go to an audiologist to get accurate results, unfortunately, I have to say that we get audiograms here from all kinds of sources. It can be not an audiologist, it can be an audiologist that aren't well done, and we repeat the testing. I would hope that somebody who is trained and goes through a doctorate program would be more accurate, but there are individuals who are out there that are not audiologists who can do accurate hearing tests. And so I wouldn't throw them under the bus. And just as likely, there can be professionals that are not doing good quality work as well.
Hello, if no one is going, I have a question. This is Tana Cooley. Hi. I've been getting audiograms since I was 3, and I understand that techniques have changed a lot for newborns and young children, but it doesn't seem to me that in all those 65 plus years that audiograms have changed that much, or the techniques have changed that much for adults. I'm wondering if there's going to be any strides forward for testing, or if there's any research for better testing of people, or if it's just tried and true, that's the way it's going to be, you know?
There are some tests. They're not super new per se. We've been using them maybe for 25 years clinically, that are part of the objective battery that I didn't go over because we don't use it for every patient. Not every patient requires that. We can get reliable, repeatable, accurate results using the methods that I described. But there are cases where there are individuals who are unable to participate in some of the parts of a typical hearing test, for which we can then do objective tests. Some of these are the very same tests that we use on infants and newborns. I'm sure you're all familiar with the fact that in California, all newborns are screened for hearing loss before they leave the hospital. Well, surely we are not having babies raise their hand or push buttons. And so we have to do other means of checking their hearing. So we can look for activity, responsiveness from the hair cells in the cochlea to stimulation in the ear that doesn't require any participation or active response from the listener. We can also check brain waves in response to audibility of sound information that's delivered to the ears. So we do have those mechanisms. And there are others that are not yet quite really routinely clinically used, also looking at brain activity in response to sound.
Yeah, I think that the newborn test would have been very helpful for me when I was born, because clearly my hearing was very profound. It was not caught till I didn't start speaking. But for instance, I'm thinking of the real ear test that you give with hearing aids, and maybe I'm just really tired of raising my hand and not raising my hand and repeating the same words for years and years and years. It doesn't, I know you want the repetitiveness that gives you information, but I'm really bored. I'm just wondering if there's more higher quality data that can be gotten at some point. If they can do it with real ear, why can't you do it in newborns? Why can't you do it with adults? That's all. Thank
I
you.
hear you, and I bet because you've probably done thousands of hearing tests, and even with the multiple lists of 50 words and what have you, at some point it probably has gotten ingrained into your auditory memory.
All up here.
That's for us, I think.
Mhm.
Consider that
Yeah.
and do something that's more intriguing and interesting.
Thank you.
Can I ask, oh, other people?
Cindy?
Hi, I'm still confused about the difference between like a bone conduction hearing loss and a nerve conduction hearing loss. And so can this, because I have a nerve loss, and does a cochlear implant work for that?
The difference is if it's a nerve hearing loss, that means that the physical location of the hearing loss is in the cochlea, where the nerve endings are from the auditory nerve. If it's a bone hearing loss, that means that there's something in the pathway of the conduction of sound, something in the ear canal, like a plug of wax, like a Q-tip piece that's stuck in the ear, like an infection that inflamed the ear canal and closed it off so sound can't get by, or something wrong with the eardrum, a hole in the eardrum, or something behind the eardrum. The bones are stuck and stiff in place. So that's the difference. Does that help?
No, well, I'm wondering, does the implant work for both types? That's my real question.
I got it. So typically, we can do other things like remove the earwax, give antibiotics for ear infections. Usually, conductive hearing losses can be medically treated. Implants are primarily designed for individuals who have a loss in the nerving because there is no other medical treatment per se to improve the hearing. Not yet at this point. They're working on that. And until they do, then if a hearing aid no longer is providing enough benefit, then a cochlear implant could be.
Okay.
The answer.
So yeah, I've had hearing aids since I was 30, I guess. And the newer ones have worked better, but they're getting harder and they're getting worse. I mean, my hearing seems to be getting worse. I don't hear as clearly anymore. I'm having more and more trouble. So I was just curious if that, I just don't really know much about the cochlear implants and I'm trying to gather information. So thank you.
You're welcome. And hopefully someone can refer you to a facility that evaluates so you can get more information about whether you are or not. And if you are, what the ramifications of that would be so that you can make a decision. I do want to add to that cochlear implants can be appropriate for mixed hearing loss. So there are people who have both a nerve hearing loss and a conductive hearing loss at the same time. Is there anyone that I'm not seeing on the screen who maybe has their hand up?
Leslie, do you have a question?
Yeah, just a follow-up. You sort of mentioned the ABR and the OAE, acoustics and measure, whatever. If you could talk a little bit more about them, and in particular, I had heard with respect to the OAE that the way that works is sound only, if you can't hear sound, then your ear doesn't emit sound. And that's why they put clicks in and measure what comes out. Can you talk a little bit about how those tests work?
Yeah, so actually the otoacoustic emissions, the OAEs, they're fairly sensitive. In other words, the hair cells become active and create this echo that can be measured in the ear canal. If there is hearing loss, that goes down to 35 decibels. So if there's a response there, that means that there's there's hearing better than 35 decibels. So we can test people normal to mild hearing loss. If the person has greater hearing loss than that, then you're right. There is not going to be a response on the OAE. It does require that the eardrum, the ear canal space usually be pretty healthy as well. We can sometimes measure an OAE in an ear that has mild middle ear issues, but problems in the middle ear can also result in an absence of OAE responses. I'm seeing here in the chat too, there's a question here about how clarity and processing of the audio signal is measured.
And Diane has a question.
Okay, I'm not exactly sure what the question about the clarity and processing means. Maybe if someone could just explain that a little bit more, whoever posed that question, then I'm happy to let you know if I've got an answer. Do you not want to? Was that? If you want to respond in the chat just to provide more information, I'll check that again. I see a question from Diane about with a CI, is one's natural hearing destroyed in that ear? We see about a 50% loss of usable natural hearing in the ear that receives the cochlear implant.
That's a big loss. I mean, that's part of
It
why
can be.
it's such a huge decision. Yeah.
Mhm.
And
That's
I,
why, go ahead.
no, well, I have another question. So what, were you in the middle of a sentence? Were you
I
in
was
the-
going to say that's why I feel that it's really important for us to inform patients so that they know as much as possible what the potential outcomes would be,
right.
and it's not reversible. So,
And my other question is that my audiogram has stayed the same for 10 years, but it appears to me that my ability to process the sound, I'm having more trouble. It doesn't show up on my test. I'm having more trouble. And is that my brain aging and not able to do the processing, or what's happening?
I think that that does happen. Processing, meaning the ability to take the information that's coming in through the ears and making sense out of it, can change as we get older. It can become more difficult. That's part can be why individuals notice I'm having more trouble than I used to hearing in noise. It may not be a change in the actual hearing acuity, how softly you can hear things. It can be in the ability of the brain to get rid of the noise or not focus on the noise and just listen to what you want to listen to. Sometimes there are tests that can be done that show that. I've seen patients that there isn't a change in how softly they can hear any of the tones, but I can see on their word recognition score, that test where we turn the speech up to where it's loud but comfortable to them, and we have them repeat a list of 50 words and calculate the percentage that's correct. And I've seen that that can change even though the access to the sound doesn't. And that becomes more challenging because it's not about putting more sound in the ear necessarily. We may be able to get the sound there and make it audible, but we can't make it sound clearer or the brain to process that sound, whether it's fast speech, which can become more difficult when processing starts to decline, speech and noise, speech that just isn't clear for whatever reason is harder to decipher than it used to be. Those are can be symptoms of processing difficulties and changes. Even with a cochlear implant, that's something that a cochlear implant can't fix either if it's a processing disorder, because that's up higher beyond what the cochlear implant.
Thank you for that bad news. Thank you.
Some testing to be done to see if you're being tested in those situations. If you're being tested with noise in the background, to see if you have more difficulty than other people have. We know that individuals who have hearing loss don't hear as well in noise as people who don't have hearing loss. But do you have more difficulty than people with hearing loss do for your degree of hearing loss? And there are tests that audiologists can do to let you know that. And in those cases, if it is primarily because of noise or distance, then making use of accessories like remote microphones or streaming sound might be the way to help to get around that difficulty.
Right, I do use a remote mic, and that, yes, it does help. Okay, all right, this is helpful. Thank you very, very much.
You're welcome. There's a question here too about if humans are primarily the victims of hearing loss as opposed to other primates and species. And so from that, and I know that they often use animal models, but oftentimes those animals have hearing loss imposed upon them through some means. There are some studies that have been done on animals that have genetic hearing losses as well. Humans, even humans, we can't discount our noisy environments. They've found groups of people who are into their 70s and 80s that don't have hearing loss, as we might expect in a more noisy environment. And so that tends to tell us the contribution that our environment has on our hearing loss. Let's see, what else does it say here? There's a question about if there's research being done on fully electromechanical ear. I know that there is research that's being done on implantable technology. So I don't know if that qualifies for that. There are already implantable hearing devices for, say, those conductive type of hearing losses to replace some of the mechanical function that's impaired in the conduction hearing loss.
Okay,
Brown has a
Jim.
question.
Okay, are you ready?
I'm ready.
Okay. I understand you explained that audiograms measure hearing loss in decibels at various frequencies. And now you recently referred to hearing loss expressed as a percentage. How can those be equated or compared?
Oh, that's true. A full evaluation is going to look at how softly a patient can hear different tones. It's because speech is made up of different tones. So it's related to speech. And most people, their concern about their hearing is they're not able to communicate. So they're concerned about their ability to understand speech. So that's where the word tests, the speech reception thresholds, and the word recognition come into play. Is a relationship between the two. Somebody earlier mentioned that having a high frequency hearing loss affects the ability to understand speech. And that's because high frequency speech sounds are the ones that give the clarity to speech. So it's the words that we get the percentage from, and we apply that with the degree of hearing loss. So it could be somebody who has a moderate to severe hearing loss and they have a word recognition score of 68% with that hearing loss. I mentioned too that sometimes we see disparities between the two where they don't seem like they go together. And in those cases, it may warrant doing other examinations. One case could be where there's a severe processing disorder where we could see a person actually hears all the speech sounds, and yet they're not understanding speech, even though they can hear it. That help you put it together?
Okay, so word recognition score of 40% is not good.
It is not. That's considered poor.
Okay.
But that might be expected based on the degree of hearing loss.
Thank you.
How are we doing on the time?
Yes, are there any more questions? Rich Schneider, you have a question?
Just a quick one. Everything else being equal, if a right ear drum is significantly damaged, ruptured, but heals after subsequent infection, will it always be less than the left ear efficiency?
Not necessarily. Once it heals, if it heals well and there's no scar tissue, then it may be able to restore back to whatever the baseline hearing was before that trauma occurred. But, ruptures to the eardrum, repeated trauma can cause scar tissue that can thicken it. You can have issues then with the bones behind the ear that prevent the eardrum from being able to transmit sounds, or just that chain of bones to the cochlea as well. And so in that cases, you may see residual hearing loss because of that.
I was just curious because my right eardrum was ruptured with a 185 decibel blast.
Wow.
So I don't know if forever that the right ear will be less than the left.
The other thing as well is the hearing. Do you have a hearing loss in that ear that's nerve hearing loss as opposed to conductive hearing loss?
Hmm.
Because I could imagine that if the eardrum was ruptured due to a traumatically loud sound, that it can also cause nerve hearing loss. And in that case, then the hearing loss is not a result of the damage to the eardrum, but from the sound pressure forces in the cochlea.
Okay, thank you.
You're welcome.
So, thank you very much, Dr. Polite, for being with us today. You brought up, so much information that I think we're going to, me personally, I have to study more, have to watch this again, and you answered questions that I know people have been wondering about for some time. So we want to thank you for being here. Thank you for taking the time to be with our chapter and for giving us your expertise. So with that, if you'd like to stay on, we're going to continue with chapter announcements. If not, then we hope to see you again. And you'll see yourself on YouTube in this soon.
All right. Thank you very much.